Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you so much for that very generous introduction, and thank you all for having me today to talk about these IAS 2022 conference highlights. So I have no disclosures, and this is just a disclaimer that any trade or brand names I use are just for training and identification purposes. So as you can imagine, this is a huge conference. There's a lot of updates, and I tried to narrow it down to some things I thought were particularly interesting and relevant. So I was going to start off with some prevention updates with HPTN 083 and 084, and then a little blurb about PrEP inequity. And then I'll move on to treatment with some new data looking at TAF versus TDF for HIV and hepatitis B coinfection, updates from the advanced trial from 2019, now updated, and then some updates in the world of long-acting injectable cabotegravir and rilpivirine. So starting out with prevention. So this was a late breaker abstract that looked at specifically transgender women in HPTN 083 and specifically the use of gender-affirming hormone therapy with long-acting injectable cabotegravir. So I'll remind us all that HPTN 083 demonstrated superiority of long-acting cabotegravir as compared to daily oral TDF-FTC for HIV prevention in men who have sex with men and in transgender women who have sex with men, and the latter is the group we're focusing on now. So in that trial, 12.5% or 570 of the participants enrolled were self-identified transgender women. About 58% of those individuals reported the use of gender-affirming hormone therapy. Just as an update, HIV incidence during the blinded phase in that group was 1.8% in the daily oral PrEP arm versus 0.54% in the long-acting CAB arm, with a hazard ratio of 0.34 in the direction of cabotegravir, with similar incident STI rates. There were no meaningful differences in adverse events, but I should note that regardless of arm, transgender women reported increased sexual, physical, emotional, and interpersonal violence as compared to men who have sex with men. Here, the investigators looked at a subset of transgender women, and they were looking in this graph specifically at cabotegravir pharmacokinetics compared in the presence or absence of gender-affirming hormone therapy. So in this subset, they looked at 30 individuals who did access hormone therapy and 23 who did not. All study participants in this analysis received all of their long-acting CAB injections on time through week 53. And what this graph shows is cabotegravir concentrations in both groups, and we can see that they're pretty comparable between groups, suggesting a lack of gender-affirming hormone therapy effect on cabotegravir PK. So, in conclusion, long-acting injectable cabotegravir is safe and effective for transgender women. Consistent with the overall HPTN 083 findings, transgender women on long-acting CAB had lower incidence of HIV as compared to daily oral PrEP. And finally, gender-affirming hormone therapy does not appear to impact cabotegravir concentrations and will need longer-term data. All right, moving on to HPTN 084. So this trial, we'll remember, previously demonstrated superiority of long-acting CAB as compared to daily oral PrEP, but this time in individuals assigned female at birth. And as a recap of what we know from that trial, in terms of HIV incidence, cabotegravir was 0.2 infections per 100 person years, daily oral PrEP 1.85, for a hazard ratio of 0.12, so quite impressive in this group. This is an update on the 12 months post-unblinding, so participants were unblinded and continued on the randomized study regimen pending approval of the amendment to offer open-label cabotegravir. So what I have here is on the left is a smaller graph that looked at the results from the initial trial. So in the blinded trial, there were 40 total incident HIV infections, 4 in the CAB arm and 36 in the TDF-FTC arm. In the larger graph, I have the combined unblinded and blinded data, but I'll tell you that in the unblinded data, there were 23 new incident infections, 3 in the cabotegravir arm, 20 in daily oral PrEP. Actually, 2 of the cases, 1 in each arm, were determined retrospectively to have occurred in the blinded periods. And the total is only 6 in the CAB arm. That math didn't make sense to me for quite some time because 1 infection from the blinded period was determined to be at baseline and was thus excluded from further analysis. And just to give you some more granular data about those infections, of the 3 new, 2 were in the absence of any recent drug exposure, and there was 1 that occurred prior to injections during the oral lead-in. But interestingly, for that individual, there was no quantifiable cabotegravir during the oral lead-in in that case. She did get her first injection at her first HIV-positive visit. The site-based testing didn't detect infection at that visit, but again, that was determined retroactively. And some data on cumulative pregnancy outcomes. So there were 132 total pregnancies, some of which were ongoing and pretty evenly divided between both arms. I'll note that the incidence of pregnancy was 3 to 4 times higher in the unblinded period as compared to the blinded. The majority were live births. All pregnancy losses actually occurred under 27 weeks, and the majority were under 20, and this included elective and spontaneous abortions. And the rates of pregnancy loss were consistent with the expected background rate. So, our takeaways: we're continuing to demonstrate cabotegravir's superiority over oral TDF-FTC in HIV prevention in those female at birth. There were 3 additional cabotegravir group infections, all with either no or poor use, and no on-injection infections were observed. And pregnancy data looks safe so far. I think the interesting caveat is the incidence being up in the unblinded was interesting to me. I hope that's, and I think the investigators also hoped that's because participants felt safer in the context of highly effective PrEP, but really highlights the need for more data on both safety and PK in pregnancy. And finally, I'll end our prevention section with this presentation on trends in PrEP inequity by race and census region in the United States from 2012 to 2021. If any of you have used AIDSview.org, this might look familiar to you. They do some really nice maps of both HIV incidence and PrEP use. And here the investigators used commercial pharmacy data to enumerate PrEP users by race and US Census region from 2012 to 2021. And they utilized something called the PrEP to need ratio, which is the number of PrEP users over the number of people newly diagnosed with incident HIV. And so what we're really looking at with that ratio is the prescriptions relative to epidemic need. And so a higher number is actually better in this case, to simplify it. What you can see here is the highest PrEP to need ratio was in the Northeast. It was lowest in the South. But I think what's really, really striking is in each quadrant, the PrEP to need ratio is highest among white race and ethnicity, followed after a dramatic drop by Hispanic and Black populations. And what I think is really horrifying is how much that's been widening more recently. So I think this is just to really highlight, again, as we think about PrEP prescribing and access in the US, to really think about who we need to be targeting. So with that, I'll switch over to some updates in treatment. So the ALLIANCE study is a new study that's a phase 3 RCT of a TAF-based HIV regimen, in this case BIC-TAF-FTC, versus TDF-FTC plus dolutegravir as initial treatment in patients co-infected with HIV and hepatitis B. And these are the week 48 results. So the big tenet of HIV and Hep B co-infection has really been to maintain a tenofovir-based regimen with the addition of either 3TC or FTC. There have been no randomized studies of TDF versus TAF-based ART and co-infection and initiation of treatment. So this study looked at adults with co-infection who were treatment naive to both HIV and hepatitis B, and those individuals were randomized to either the TAF-based regimen or the TDF-based regimen. You can see here that everyone included was both HIV viremic and hepatitis B viremic. They had to be susceptible with respect to HIV to tenofovir and FTC. And then the randomization was stratified by a few factors like hepatitis B, E antigen positivity, the degree of Hep B viremia, and CD4 count. There were 2 primary endpoints, and they were basically HIV viral suppression and hepatitis B viral suppression. So here you can see the distribution within groups. What you can see is the majority of these participants were male. They were mostly Asian. This was a multi-site study, but the majority of participants were from Thailand, China, and Malaysia. They had a pretty similar median CD4, and around half had a CD4 under 200. And you can see again among those other stratified groups, like the E antigen positivity, they're pretty similar in distribution. And so here are both of our endpoints. And the green bar is the TAF-based group, and the gray bar is the TDF-based group. And the big takeaways here is that for the HIV endpoint, viral suppression of HIV RNA, TAF was non-inferior to TDF. For the hepatitis B endpoint, TAF was actually superior at the 48-week mark, 63% achieving viral suppression versus 43%. I've also included this bullet point that the investigators had about CD4 change from baseline, similar but higher definitely in the TAF group, so a 200 increase of 200 versus mean increase of 175 in the TDF group. They also presented another figure that I have not included here that showed that the Hep B viral load decrease over time was very similar between groups, so similar rates of viral decay on therapy. And here, the investigators present surface antigen loss and seroconversion for hepatitis B, along with E antigen loss and seroconversion for the participants who were initially E antigen positive at baseline. So up at the top, looking at hepatitis B surface antigen, you can see that there were higher rates of surface antigen loss and seroconversion in the TAF group, although these were non-significant changes. And among the E antigen group, there were higher rates of E antigen loss in the TAF group, again, not significant, but significant higher rates of seroconversion. I didn't include this figure here, but there are also non-significant higher rates of ALT normalization in the TAF group. So takeaways here, as compared to a TDF-based regimen, a TAF-based regimen in HIV and hepatitis B co-infection was non-inferior at achieving HIV-1 RNA suppression, superior at achieving hepatitis B DNA suppression, and with higher rates of hepatitis B antigen seroconversion with similar safety. I think the question that the investigators are asking is TAF better? And I wasn't sure what to make of this at first, and I asked David Spock in clinic yesterday too, but I think everyone's suspicion is that it's probably too early to tell, and we'll have to see at 96-week and even further along data. Next, moving on to the ADVANCE trial. So this was a trial, I think that was published initially in 2019 in the New England Journal, that was looking at two formulations of tenofovir, TDF or TAF with FTC plus dolutegravir, and then TDF FTC efavirenz. And this was designed as a non-inferiority study, but I think the big takeaway from that study, and that was maybe a bit of a surprise, was the weight gain in the dolutegravir arms. And so just to remind everybody, that was highest in the TAF plus dolutegravir group, then TDF plus dolutegravir, and then in the TDF efavirenz group, minimal weight gain. And that weight gain was most pronounced in women, those with lower CD4 counts, and higher viral loads. The investigators actually had a trial extension up to week 192 that they're presenting here for longer-term follow-up of the weight gain and adverse events. So I'm including here these, I think, pretty striking graphs of both female and male weight gain and time to enrollment. And just to summarize, now at 192 weeks, the body weight increases were pretty profound. So 9 kilos in the TAF plus dolutegravir group as compared to about 3 in the TDF efavirenz. Risk of clinical obesity was highest in the TAF plus dolutegravir group, with 29% achieving that by week 192 in female patients and those with higher baseline BMI. And the proportion of women who developed clinical obesity by almost a little over 3.5 years was 43% in the TAF plus dolutegravir arm. I think the other important thing that these graphs illustrate are that you see that the tempo of increase in weight, again, as we've known from both this and other trials, that it's really in the initial 48 weeks that we're seeing that rapid weight gain. The investigators also presented data on metabolic syndrome, and the takeaway here is that that risk of emergent metabolic syndrome, meaning having emerged, not emergency in this case, was significantly higher in the TAF arm. Bone fracture and higher grade renal adverse events were rare and similar across both arms. Oh, and I should say that metabolic syndrome here was defined by the International Diabetes Federation, so that had to be central obesity plus 2 of 4 elements, which were raised triglycerides, reduced HDL, raised blood pressure, and raised fasting plasma glucose. So takeaways here, there were substantial weight gain differences maintained at 192-week follow-up in the ADVANCE trial. These continued to be most pronounced in the TAF plus dolutegravir arm in women and in those with higher baseline BMI. There was a higher risk of metabolic syndrome and clinical obesity in this group. With respect to TAF versus TDF, there were no real differences in RNA suppression or renal and bone-related adverse events. And both groups had higher rates of viral load suppression compared to the efavirenz-based therapy. I'll just take one moment to say that this was not the only trial presented that commented on weight gain at longer-term follow-up. So the NAMSOL trial, which I think was published around the same time, came out of Cameroon, and that was looking at TLD, or TDF lamivudine dolutegravir versus TDF 3TC and efavirenz. That was also presented with 4-year outcomes. And in that, so there's no TAF in that case, but at least TDF and dolutegravir, that group of women gained 8 kilos as compared to 5 kilos. Also interesting, when I was kind of looking at abstracts related to weight gain, there was a poster on week 96 weight gain and lipid changes for cabrilpivirine from both ATLAS and FLAIR data. That was compared to Triamex, so abacavir 3TC dolutegravir, and there were only very minor changes in weight gain and lipids, so suggesting that maybe cabotegravir doesn't have the same risk as dolutegravir or bictegravir in terms of weight gain. So speaking of injectable cabrilpivirine, a couple of posters from ViiV looking at delivery methods. So as I think has been brought up many times at this ECHO, is one limitation is the buttock injections. And so people are interested in, can we deliver it other ways? This first study I cited looked at PK and tolerability of lateral thigh injection and found it to be safe, tolerable, with PK ranges that support further evaluation at least. I will note that the median BMI in that group was 31.4, which is, I think, something to think about in the context of high BMI and clinical failure. The second abstract, looking at PK, looked at higher concentration cabrilpivirine. And so the investigators looked at 400 mg per ml instead of 200 mg per ml. They were looking monthly still at this point. And the goal, though, is to see whether a higher concentration for more frequent dosing or self-administration could do better. And it was tested at IM gluteal, sub-Q abdominal, and IM thigh, and was found to be safe, tolerable, and acceptable. Doesn't mean that they're necessarily ready for prime time, but at least the PK looks somewhat promising. And then I just had to include this abstract that looked at delivery of cabrilpivirine in people with HIV with and without detectable viremia. The plug I'll give is now this is actually a published manuscript in CID as of, I believe, last month. But here, Ward 86 at UCSF, this group looked at 51 patients that were initiating injectable cabrilpivirine. And they specifically looked at 39 individuals with at least 2 follow-up injections. What they were really focusing on here is what I think many of us have been waiting for long-acting injectables for patients who really have difficulty engaging in care and taking ART. And so within this sample, there were 24 individuals who they started on the injectables while suppressed, and 15 while viremic. So obviously this part is controversial. 100% of those suppressed maintained viral suppression after initiating injections. And of the viremic patients, 12 achieved and maintained viral suppression. I believe the manuscript data is up to 9 months now. And the remaining 3 had a 2-log decline by a median of 22 days. So this is not to say that we should feel safe or feel great about viremia and cabrilpivirine, but I think thinking about why this was developed and who it might have the highest impact for is really interesting and exciting. And I think there was a Paul Sachs commentary where he said something like, in 2022, nobody should be dying of HIV complications if there is an ART option available. I think he said it better than I did. So big takeaways: long-acting injectable cabotegravir continues to be a superior and safe PrEP option for people assigned female at birth, including in pregnancy, although more to come on that. Safe and effective for transgender women, including those on gender-affirming hormone therapy, and it's improving with respect to delivery methods when co-formulated with rilpivirine as treatment, looking at different places it can be injected, and then literal delivery to different patients. There are continued and worsening inequities in access to and use of PrEP in the US, persist regionally and by race and ethnicity. Switching to treatment, TAF might be better than TDF in HIV and hepatitis B co-infection, maybe, we'll see. And dolutegravir, especially with TAF, continues to be really strongly associated with weight gain, risk of metabolic syndrome, and clinical obesity. And that is all I have. Thank you, everybody, for your time, and any questions I can try to help clarify or answer. I'm excited to do so.
Thank you for watching this edition of the Mountain West AETC Project ECHO Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.